CBT for anxiety. Part C. Irrational thinking in anxiety is normal and understandable. The thoughts are designed to keep us safe. Although this is the intended consequence, this type of thinking can have disastrous effects. It leads us to overestimate risk unhelpfully and inaccurately. It leads to behaviors that stop us finding out that things are not as bad as they seem. History taking and diagnosis. Important points. In what specific situations does the patient get anxious? Ask for a typical recent example. What are the thoughts, physical feelings and behaviors or urges that go with that? Be as specific with maximum attention to detail. Physical symptoms of anxiety. What are they for? What might people experience? Increase in heart rate and strength of heartbeat. Enables blood and oxygen to be pumped around the body faster. Experience of palpitations or heart pounding. A redistribution of blood from areas that are not as vital. For instance, away from fingers and toes. Pale fingers, toes. Numbness and tingling in fingers, toes. An increase in the rate and depth of breathing. This allows more oxygen into the body. You may notice sighing, yawning, breathlessness, smothering, tightness, pain in the chest. Low CO2 causes constriction of blood vessels in the head, leading to reduced oxygen in the brain, which can cause short-term dizziness and visual disturbances. Hyperventilation also leads to numbness, tingling particularly in hands and feet and around the mouth, and can lead to pins and needles and muscle cramps in the extremities. Muscle tension. Preparation for fight. Aches, pains, trembling, shaking, and later exhaustion. Decreased activity of the digestive system. More energy to fight-flight systems. May notice decrease in salivation, dry mouth. Nausea, heavy stomach. Widening of the pupils of the eyes. Blurred vision, spots before the eyes, light too bright. Increase in sweating. More slippery, harder to grab, cooling the body. Model-informed assessment. Symptoms. What are the key symptoms of anxiety that trouble the client? Indications of concurrent physical problems. Catastrophic misinterpretation. The nature of the feared consequence will significantly guide diagnosis. For instance, I am having a heart attack. Avoidance and safety behaviors, secondary problems. Avoidance leads to restriction of activities which can lead to depression. Shame, guilt about the problem. Alcohol use as coping strategy. Impact on relationships exercise. Reformulating clients' panic problems on the basis of workshop learning. Panic attacks. Sudden increase in anxiety, accompanied by physical and mental symptoms. Dizziness, sweating, palpitations, etc. Common in all anxiety disorders as well as other problems. Recurrent attacks. Fear of further attacks. Almost invariably a secondary fear of dying, losing control, going mad. Worry about the implications of the attack, not owing to other conditions. With or without agoraphobia. Agoraphobia. DSM-5. Fear or anxiety about at least two of the following. Using public transport, open spaces, being in enclosed places. Standing in line or being in a crowd. Being outside of the home alone. Fear or avoidance because you think that escape might be difficult or help might not be available in the event of developing panic-like symptoms. Treatment. Development of shared understanding. Formulation. Psychoeducation. Identify that the threat is fear of physical symptoms of anxiety, which creates a vicious cycle. Cognitive techniques. Develop alternative explanations for the physical symptoms. Behavioral experiments. Symptom provocation. Tests allow patients to experience feared physical symptoms without the feared catastrophe happening. Attentional training. Psychoeducation refers to the process of providing education and information to those seeking or receiving mental health services, such as people diagnosed with mental health conditions and their family members. It is a vital intervention in the work of a CBT therapist. The therapist will educate the client regarding fight-flight mechanisms, effects of adrenaline, safety-seeking behaviors, avoidance, its logic and effects, selective attention, address avoidance and safety behaviors, pros and cons of existing strategies, validating current coping. Many clients self-blame and self-shame. This reduces self-efficacy, thus decreasing likelihood of engaging in newer, more productive behavior. Testing of specific predictions. Engaging curiosity rather than self-driving. Test in session wherever possible. Increase or decrease behaviors and study effect. Drop behaviors in feared situations. Hierarchies. In situ therapist assistance. Emphasize caution. Summary. Misinterpretations of sensation in panic disorder are understandable mistakes. Behaviors logically follow thought. Maintenance of unhelpful belief equals unfortunate side effect of behavior. Vigilance increases proportion of negative information available to client. Arousal creates new sensations. The non-event is attributed to the safety behavior. Behavioral change is the acid test of CBT of all the anxiety disorders. If there is no behavioral change, then the therapy is not working and different interventions are required. End of Unit 6. To gain a deeper knowledge and understanding of the topics discussed in this unit, please study the PDF materials provided and watch the remaining videos for this unit. You can submit your second assignment at this stage.